Good afternoon, dear students. Today, the topic of our lecture is chronic obstructive pulmonary disease and bronchial asthma. Definition. Chronic obstructive pulmonary disease is a common, preventable, and treatable disease that is characterized by persistent respiratory symptoms and airflow limitation that is due to airway and/or alveolar abnormalities, usually caused by significant exposure to noxious particles of gases and influenced by host factors, including abnormal lung development. Significant comorbidities may have an impact on morbidity and mortality. COPD is a leading cause of morbidity and mortality worldwide and results in an economic and social burden that is both substantial and increasing. Patients typically have symptoms of chronic bronchitis and emphysema, but the classic triad also includes asthma or a combination of three conditions together. Chronic bronchitis is defined clinically as a presence of a chronic productive cough for 3 months during each of 2 consecutive years. Emphysema is defined pathologically as an abnormal permanent enlargement of the air spaces distal to the terminal bronchioles, accompanied by destruction of their walls and without obvious fibrosis. In Western Europe, Betham and Olena made the classic descriptions of chronic bronchitis and emphysema in the early 19th century. A British medical textbook of the 1860s described the familiar clinical picture of chronic bronchitis as an advanced disease with repeated bronchial infections that ended in right-sided heart failure. The primary cause of COPD is exposure to tobacco smoke. Overall, tobacco smoking accounts for as much as 90% of COPD risk. Cigarette smoking includes macrophages to release neutrophil chemotactic factors and elastasins, which lead to tissue destruction. Clinically significant COPD develops in 15% of cigarette smokers. Also, this number is believed to be an underestimate. Age of initiation of smoking, total pack years, and current smoking status predict COPD mortality. Airway hyperresponsiveness stipulates that patients who have nonspecific airway hyperreactivity and who smoke are at increased risk of developing COPD with an accelerated decline in lung function. Non-specific airway hyperreactivity is inversely related to FEV1 and may predict a decline in lung function. The role of air pollution is in the etiology of COPD is unclear. The effect is small when compared with that of cigarette smoking. In developing countries, the use of biomass fuels with indoor cooking and heating is likely to be a major contributor to the worldwide prevalence of COPD. Alpha-1 antitrypsin is a glycoprotein member of the serine protease inhibitor family that is synthesized in the liver and is secreted into the bloodstream to protect the lung parenchyma from elastonic breakdown. Severe AAT deficiency predisposes to unopposed elastolysis with the clinical sequela of an early onset of Ventricular emphysema. Emphysema occurs in approximately 2% of persons who use intravenous drugs. Human immunodeficiency virus infection has been found to be an independent risk factor for COPD, even after controlling for confounding variables such as smoking. Pathologic changes in chronic obstructive pulmonary disease occur in the large airways, the small bronchioles, and the lung parenchyma. Most cases of COPD are the result of exposure to noxious stimuli, most often cigarette smoke. The normal inflammatory response is amplified in persons prone to COPD development. The pathogenic mechanisms are not clear, but are most likely diverse. Increased numbers of activated polymorphonuclear leukocytes and macrophages release elastasis in a manner that cannot be counteracted effectively by antiproteases. Resulting in lung destruction, cigarette smoke causes neutrophil influx, which is required to the secretion of macrophage-derived matrix metalloproteinases. This suggests, therefore, that neutrophils and macrophages are required for the development of emphysema. The primary offender has been found to be human leukocyte elastase with synergistic role suggested for proteinase 3 and macrophage-derived matrix metalloproteinases. Cysteine proteinases and a plasminogen activator. Additionally, increased oxidative stress caused by free radicals in cigarette smoke, the oxidants released by phagocytes and polymorphonuclear leukocytes all may lead to apoptosis or necrosis of exposed cells. Accelerated aging and autoimmune mechanisms have also been proposed as having roles in the pathogenesis of COPD. In patients with stable COPD without known cardiovascular disease, there is a high prevalence of microalbuminuria, which is associated with hypoxemia independent of other risk factors. Emphysematous destruction and small airway inflammation often are found in combination in individual patients, leading to the spectrum that's known as COPD. When emphysema is moderate or severe, loss of elastic recoil rather than bronchial disease is a dominant mechanism of airflow limitation. By contrast, when emphysema is mild, bronchial abnormalities are most responsible for the majority of the deficit in lung function. Also, airflow obstruction in emphysema is often irreversible. Bronchial obstruction due to inflammation accounts for some reversibility. Mucous gland hyperplasia in the histologic hallmark of chronic bronchitis. Airway structural changes include atrophy, focal squamous metaplasia, ciliary abnormalities, variable amounts of airway smooth muscle hyperplasia, inflammation, and bronchial wall thickening. Damage to the endothelium impairs the mucociliary response that clear bacteria and mucus. Inflammation and secretions provide the obstructive component of chronic bronchitis. Neutrophilia develops in the airway lumen and neutrophilic infiltrates accumulate in the submucosa. The respiratory bronchioles display a mononuclear inflammatory process, lumen occlusion by mucus plugging, doublet cell metaplasia, smooth muscle hyperplasia, and distortion due to fibrosis. These changes, combined with loss of supporting alveolar attachments, cause airflow limitation by allowing airway walls to deform and narrow the airway lumen. Emphysema leads to a dramatic decline in the alveolar surface area available for gas exchange. Furthermore, loss of alveoli leads to airflow limitation by two mechanisms. First, loss of the alveolar walls results in a decrease in elastic recoil, which leads to airflow limitation. Second, loss of the alveolar supporting structure leads to airway narrowing, which further limits airflow. The gradual destruction of alveolar septa and of the pulmonary capillary bed in emphysema leads to a decreased ability to oxygenate blood. The body compensates, which lowered cardiac output and hyperventilation. This relation mismatch results in relativity limited blood flow through a fairly well oxygenated lung with normal blood gases and pressures in the lung. In contrast to the situation in chronic bronchitis. Because of low cardiac output, the rest of the body also suffers from tissue hypoxia and pulmonary cachexia. Eventually, these patients develop muscle wasting and weight loss and are identified as pink puffers. Emphysema characteristics include the following. Patients may be very thin and with a barrel chest. Patients typically have little or no cough or expectoration. Patient may be assisted by pursed lips and use of accessory respiratory muscles. Patients may adopt the tripod sitting position. The chest may be hyper resonant and wheezing may be heard. Heart sounds are very distant. Overall appearance is more like classic COPD exacerbation. Diagnosis and assessment. The clinical diagnosis of COPD should be considered in any patient who has dyspnea, chronic cough, or sputum production, and a history of exposure to risk factors for the disease. Spirometry is required to make the diagnosis in this clinical context. The presence of a post-bronchodilator, FEV1, FVC less than 0.7 confirms the presence of persistent airflow limitation of SARS of COPD. The goals of COPD assessment are to determine the severity of the disease, including the severity of airflow limitation, the impact of the patient's health status, and the risk of future events, in order to guide therapy. Comorbidities occur frequently in COPD patients, including cardiovascular disease, skeletal muscle dysfunction, metabolic syndrome, osteoporosis, depression, and lung cancer. Given that they can occur in patients with mild, moderate, and severe airflow limitation and influence mortality and hospitalization independently, comorbidities should be actively looked for and treated appropriately if present. Pulmonary function tests are essential for the diagnosis and assessment of the severity of disease, and they are helpful in following its progress. In addition to the spirometry findings that define the disease, lung volume measurements often show an increase in total lung capacity, functional residual capacity, and residual volume. The vital capacity often decreased. Dynamic hyperinflation during exercise is now thought to be a greater contributor to the sensation of dyspnea than airflow obstruction alone. Carbon monoxide diffusing capacity is decreased in proportion to the severity of emphysema. Spirometry is the most common of the pulmonary function tests measuring lung functions, especially the measurement of the amount, volume, and or speed flow of air that can be inhaled and exhaled. Spirometry is an important tool used for generating pneumotachograph to assessing conditions such as asthma, pulmonary fibrosis, cystic fibrosis, and COPD. The formal diagnosis of COPD is made with spirometry. When the ratio of forces expiratory volume in 1 second over forced vital capacity is less than 70% of that predicted for a matched control, it's diagnostic for a significant obstructive defects. Criteria for assessing the severity of airflow obstruction are as follows. In patients with emphysema, frontal and lateral chest radiographs reveal the following: flattening of the diaphragm, increased retrosternal airspace, a long narrow heart shadow, rapidly tapering vascular shadows accompanied by hyperlucidity of the lungs. Radiographs in patients with chronic bronchitis show increased bronchovascular markings and cardiomegaly. Patients with COPD can have sustained or intermittent hypoxia. Hypoxia can cause abnormalities in ventricular relaxation and contraction due to changes in the myocyte cell metabolism. Numerous epidemiological studies have shown that COPD patients have a high risk of developing CAD with its inherent complications, and that this risk increases during exacerbations. Right ventricular function and pulmonary hypertension, usually only mild to moderate, are common in COPD. Ventricular independence describes the phenomenon in which both RV pressure and volume overload cause the interventricular septum to shift toward the left ventricle. Modifying is geometry. Dilatation of the right ventricle also increases the constrictive effects of the pericardium, all of which can result in a reduction in the distensibility and filling of the left ventricle. Hyperinflamed lungs and high instinctive positive and expiratory pressure will decrease intrathoracic blood volume and ventricular preload, resulting in hypovolemic diastole. LV hypertrophy is considered an arrhythmogenic factor and can result in the eventual onset of ventricular dysfunction and atrial fibrillation and dilatation. Electrocardiography can help establish that the hypoxia is not resulting in cardiac ischemia and that the underlying cause of respiratory difficulty is not cardiac in nature. The morphological description of the heart chambers in COPD using echocardiography raises the issue of suboptimal quality if hyperinflation and diaphragmatic flattening coexist. Two-dimensional echocardiography may be helpful as a screening tool to estimate pulmonary arterial systolic pressure and right ventricular systolic function. Also, formal cardiac catheterization is necessary to accurately confirm the diagnosis. Pulse oximetry and arterial blood gases measuring. Pulse oximetry should be used to assess all stable patients with FEV1 less than 35% predicted or with clinical signs suggestive of respiratory failure or right heart failure. If peripheral saturation is less than 92%, arterial blood gases should be assessed. Medications used in COPD treatment.